do a brief, we're just getting ready to start. Do you still want to do a brief kickoff for us?
Sure.
Okay.
Hi, everybody. I just wanted to, before we get started, thank everyone for today's meeting. And I think it's important in today's world to acknowledge the positive impact that compassion and dedication can have in every circumstance. And I want to thank the Board of Nursing and the Board of Healing Arts for all that you do to help others in not just your professional lives, but also as board members. Serving on the board takes away from your job. It takes away from your families. And I know you all make a great sacrifice. And I know sometimes things can be contentious, but everyone has the same goals, which is to protect the public and to provide the best possible health care to our citizens. And I want you all to be proud of the work that you do and the positive difference that you all make in everyone's lives. So I just want to start off by just thanking all of you for agreeing to have this meeting. And, you know, sometimes I know passions run high, but that's because we all really care about our citizens. So thank you.
Okay, Bonnie, did you want to start with calling the meeting to order and doing a roll call for the nursing board members, please?
You bet. Can everyone hear me all right? Yes. Okay, great. Thank you. Good evening. I would like to call the March 28th, 2022 full board WebEx joint meeting between the Missouri State Board of Nursing and the Board of Registration for the Healing Arts to order. Let's begin with a roll call for the State Board of Nursing. Dr. Miller?
Present.
Dr. Hyen?
Present.
Ms. Kennedy?
Present.
Dr. Blow? Dr. Blow?
Present.
Thank you. Mr. Wolf?
Present.
Ms. Sly?
Present.
And Dr. Kim is here. Thank you. I now encourage the chair of the Board of Registration for the Healing Arts to conduct their roll call of their members.
You're muted.
Sorry. Good evening, everybody. I want to introduce myself. I'm Dr. Jeffrey Glazer, president of the Missouri State Board of Registration for Healing Arts. I'm going to go around and take roll call of our members. Dr. James Durena.
Present.
Dr. Catherine Matthews.
Present.
Dr. Naveed Razak.
He's muted.
Present.
Dr. Catherine Matthews.
Still present.
Sorry, I don't have the list. I just got home. Dr. James Halbert.
Present.
Dr. Jeffrey Carter.
Present.
Dr. Mark Taormina.
Present.
Dr. David Tannehill.
This is Louis.
Present.
What was that?
That was my son talking to my
Somebody
dog.
say something.
I'm present.
All right. I don't believe we have any of the members on the board called, do we, Jimmy?
No, sir.
All right.
All right, so we'll move forward with approval of agenda by the Missouri State Board of Nursing. I would entertain at this time a motion to approve the agenda as presented.
Motion to approve.
That's the first.
I'll second.
Okay, second. Call for the vote.
Julie, yes.
And yes.
Renee, yes.
Anna, yes.
Trevor, yes.
Adrian, yes.
And Bonnie, yes. I encourage approval of the agenda by the Board of Registration for the Healing Arts.
Jimmy, will you call the vote for us?
Yes, sir. Do we have a motion to accept?
Motion to accept.
Second.
second.
Okay, Dr. Glazer,
Aye.
Dr. Taormina,
Aye.
Dr. Carter,
Aye.
Dr. Durena,
Aye.
Dr. Matthews,
Aye.
Dr. James Halbert,
Aye.
Dr. Razak,
Aye.
Dr. Tannehill.
Aye.
Thank you all. The Missouri State Board of Nursing wants to extend our gratitude and our thanks to the Missouri State Board of Registration for the Healing Arts for agreeing to a joint meeting. This meeting was requested to discuss Rule 20, CSR 2200-4.200-282 and Rule 20, CSR 2150-5.100-282, while requires an advanced practice registered nurse, APRN, and collaborating physician to practice within 75 miles by road to one another. This rule has been suspended to allow a physician and APRN to collaborate regardless of where the providers are located. The specific mileage requirement is only found in the rules. State law authorizes joint rulemaking by two boards. The rules are limited to specifying geographic areas to be covered, the methods of treatment that may be covered by collaborative practice arrangements, and the requirements for review of services provided pursuant to collaborative practice agreements. If a decision is made to file a rule change, the rulemaking process will be followed, which will allow for a public comment period at that time. At this time, I invite our moderator, Christine Paulsmeyer, to begin facilitating this discussion.
Good evening. This joint meeting today is for the purposes of facilitating this discussion between the board members of both boards. Pursuant to the meeting notice posted on March 14th, 2022, public comments were received through March 21st, 2022. Both boards are in receipt of the written public comments submitted under the meeting notice. These comments will not be read or addressed separately, but the issues may be addressed or discussed as part of the dialogue today. In the interest of time, oral public comments will not be taken at this meeting. The purpose of this meeting is to allow dialogue between the board members of both boards. If a board member wishes to speak, they may use the raise hand function provided in WebEx. The executive director of each board is present with me in the meeting room and can see the raised hands in the WebEx platform. They will keep track of those raised hands, and the executive director of the respective board will recognize their board member to speak, and we will alternate between the two boards. We ask each board member to limit their comments to no more than 5 minutes before rotating to the other board to respond. We will strictly enforce the 5-minute rule, and I'll give a 1-minute warning, which looks like this. Hopefully everybody can see that. When you're recognized to speak, please state your name and the name of your board before beginning your comment. We'd ask that each board be mindful of allowing each member seeking recognition an opportunity to speak. Comments must be limited to the specific purpose of the discussion of Rule 20 CSR 2200-4.200 2B2 and Rule 20 CSR 2150-5.100 2B2, which requires an advanced practice registered nurse and collaborating physician to practice within 75 miles by road to one another. So with that, Ms. Scheich, you may call your first board member.
Do we have a Board of Nursing member that wishes to speak first? Dr. Kim? And we can't hear you right now.
Sorry about that. Can you hear me
we
now?
can hear you. Yes.
Okay. Dr. Kim, President of the Board of Nursing. Again, I want to thank the Board of Healing Arts for taking this matter up at their last meeting. I attended that meeting and appreciate the serious thought that was put into this topic. On behalf of the Board of Nursing and as President of the Board, I believe that the issue before us this evening is one of access to care. That is really what we're talking about. During the last board meeting, Dr. Toromina spoke at great length about this, and he is absolutely correct. This is an access issue. Missouri is currently the only state with a mileage limitation for all APRNs. As we all know, this restriction was waived for the last 2 years during the pandemic. In addition, this restriction does not apply to APRNs providing services through the Veterans Administration. You all proposed at your last meeting to modify the restrictions for APRNs working at correctional facilities. We at the Board of Nursing have proposed eliminating the mileage restriction entirely for all Missourians, not just those who are in correctional facilities, not just those who are receiving services through the VA, and not just those who have been able to receive this service for the last 2 years. While the modification that the Board of Healing Arts made to the rule for correctional facilities is a welcome, we believe the standard should apply equally to all Missourians. One of the stated reasons for this necessary change was the lack of availability of collaborating physicians for APRN working in correctional facilities. While problems exist for APRNs working within those facilities, these problems also exist for APRNs working across the street at the clinics. This is a statewide problem that we have been given the responsibility to address. The state legislature has specifically granted us the authority to determine geographical proximity regulations. Again, our request is that there be no mileage limitation for any APRNs within the state, regardless of the status of the patients being served. We've operated in this manner for the last 2 years and had 0 quality of care or standard of care complaints related to the geographic proximity requirement. There has been no evidence during the past 2 years that supports the 75-mile limitation. The Missouri Hospital Association has stated that its members' hospitals have reported no negative impacts to quality of care due to the waiver of the mileage limitation. There is also no evidence of patient safety issues from states that previously had a mileage limitation and eliminated it. Simply put, there is no need for this restriction any longer. The only purpose it serves is a bad purpose, that being it is restricting access to care for Missourians. If we keep a mileage restriction of any distance, we will, in effect, be removing access to care for thousands of Missourians who are able to have that care over the last 2 years due to the waiver. I understand there may be reluctance to remove this restriction. The Board of Healing Arts in its motion increased the distance to 200 miles for APRNs and correctional facilities only and required an ongoing study to be provided to assess outcomes. Again, the Board of Nursing has proposed and is once again asking that the mileage restriction be eliminated entirely. We've had 2 years of experience without this restriction. There are 49 other states that operate without this restriction. Further study of the issue is not necessary. I say to those who are concerned that there may be quality of care or patient safety issues going forward, we already have the tools in place to deal with these issues. Both boards have mechanisms for addressing patient and provider complaints. On behalf of the Board of Nursing, I can state that we take these issues very seriously and will continue to do so. I'm confident that the Board of Healing Arts does as well. If discipline of licensed individuals becomes necessary, that discipline will be legally and responsibly administered. Again, there has been no evidence in Missouri or anywhere else that the lack of mileage restriction has led to disciplinary action. This is an extremely important issue for our boards to address. The governor has asked us to address it for correctional facilities. We at the Board of Nursing agree, but we also think this issue should be addressed for all Missourians. We have proposed elimination of the mileage limitation and are urging the Board of Healing Arts to act jointly with us to do the same. In addition to the governor, the Missouri Hospital Association, Missouri Nurses Association, Barnes Jewish Medical Group, Oak Street Healthcare Centers, and countless Missouri physicians and nurses have asked us to eliminate the mileage restriction. It's time, like the rest of the country, that we permanently eliminate this barrier to access to care. Thank you for listening. And I think I'm at time.
Trying to make it stop there. Thank you. Mr. Leggett, would you like to call your next board member?
Do we have any board members that would like to speak? Raise your hand if you don't. Dr. Matthews.
You said thousands
We
of patients.
can't hear you.
I'm a data geek. You said thousands of patients had received care solely because of the waiver. I'm curious about what that information is based on.
Does she need to repeat it?
I think she was asking about the data, if I'm not mistaken.
Can you hear me now?
Yes.
Yes.
I said I'm kind of a data literalist, and so I'm curious about the source of the data that thousands of patients received care solely because of the waiver.
Are you asking that of the Board of Nursing?
Yes, you said thousands of patients had been able to receive care solely because of the waiver.
Yes. So patients, when it was waived, have access to care to APRNs because the elimination of the mileage was no longer in effect.
I was just curious about the claim of thousands.
Julie?
I can offer by way in support to that assertion that every single rural county in Missouri is a health service underserved area. Therefore, even with APRNs and primary care physicians, behavioral and mental health specialists, every single rural county is underserved. So with that data, we have to assume that access to care is improved whenever we have APRNs who are working in rural areas, and would be more likely to do so if the collaboration rule was not in effect in terms of the mileage rule.
I guess that would go back. Did you have I'm sorry, I didn't mean to cut you off. Did you have anything additional to that comment that can be answered before going back to
Dr. Matthews?
That's it. I see that two of my colleagues have their hands up.
If the Board of Nursing answered, it goes back to the Healing Arts for your next board member.
Dr. Glaser?
I just want to follow that up. So there's no data, we're just talking assumptions, correct?
Yes, that is correct. Looking at just numbers and the state, that is correct.
But I don't want to interrupt, but so there's no real numbers, we're just working on assumptions. I just want to be clear on that. There's no actual data to present that the numbers have changed or were changed as a result of this barrier.
If the Board of Nursing doesn't have a further response, would they like to have their next comment?
I do have a response.
Oh, go ahead, please.
So firstly, these were emergency waivers. So I'm not sure how much we expect any APRN to substantially change his or her practice based on emergency waivers. Secondly, the data is replete. The literature is replete with data from other states that have greater access to care when APRNs have unrestricted access, or whenever patients have unrestricted access to APRN care. The data is out there in other states. It's very clear in other states. What we're talking about now is a mileage restriction. So I guess my curiosity would be, how can one assume that as long as there is a 75-mile restriction, that APRNs aren't working in more remote areas in Missouri and that access to care isn't severely limited because of that? If we're dealing about safety, then, you know, I mean, there are no safety issues, and it's illogical to think that there wouldn't be greater access to care if they weren't tethered, if APRNs were not tethered to a collaborating physician by 75 miles.
I'm just responding to what was presented to me since it's still my time, and I'm being told that access to care was improved to thousands of people in the state of Missouri, but I don't see or hear concrete evidence to prove that. I can't do this based on assumptions in other states. I'm asking specifically about Missouri and what happened to this waiver, and the information that was presented stating that thousands of patients benefited from this waiver. So that's all I have to say. I'll pass on to the next board member.
I think Trevor has his hand up, and he has 5 minutes. So each person, I'm sorry with the rules, each person gets to speak once, and they have 5 minutes.
This is actually in response to the question by Dr. Matthews. Yes, we may not have prepared that particular set of data for you. However, with the great stressors that allowed the waivers to be enacted, it's pretty much common knowledge, if anybody paid attention to the happenings of the world at the time, that a lot of the slack that was created by the rapid influx of not thousands or tens of thousands or hundreds of thousands of patients needing testing and treatment for this pandemic, a lot of that was happening in areas where urgent cares and things like that kind of brought up the slack that the hospitals couldn't take up because we were being overwhelmed. So while we may not have that data, it's pretty well, obviously, it's common knowledge of anybody who was paying attention at that time that APRNs were picking up a lot of that to help physicians expand their area.
All right. Following that, let's see. I guess we're going back to healing arts. Healing arts.
Okay, all right. Dr. Taramina?
Are you able to hear me okay?
Yes.
Yeah, thank you everybody for this meeting. It's very helpful for me. I was able to read all the comments that were submitted by the nursing board and the Board of Healing. They were very helpful. And I want to start just by saying that I think that APRNs play a vital role in the healthcare system, and I do feel that they are performing, from what I can see and from what I see personally in my practice, an excellent role in being a physician extender and providing care, even in specialty practice such as mine. I think just an overall sort of description that there wasn't any complaints in the 2-year time frame is somewhat misleading, because many of the issues that are seen by APRNs and physicians may require a longer period of time to really see if there's any issues, such as monitoring blood glucoses, missed screening tests, et cetera, that may not really be shown on an emergency sort of complaint issue in the 2-year time frame. I think just the overall dropping of a 75-mile waiver would be somewhat of a drastic measure. I think that the technology from the 1990s, when this collaborative rule was initially initiated, to now has changed dramatically, and the use of telemedicine and the other remote monitoring mechanisms should be looked at and in a favorable light in terms of extending the mileage restriction or even waiving it in some situations. The Class C counties that have rural access issues should be waived, in my opinion. But those are things that have to be discussed in a joint way. And I would propose at some point that there be a joint committee between the Board of Nursing and the Board of Healing Arts, where we come up with some collaborative practice sort of guidelines and make the quality assurance have more teeth. I was a little upset when I saw that one APRN was having to pay $900 a month to a collaborating physician just to sign her charge, with no evidence that there was any quality measures or even quality comments made by that physician, which seems like a money grab to me, and that's really not what the Collaborative Practice Act was meant to be. And I think there ought to be some difference in the collaborative practice agreements between the primary care physicians and collaborative practice nurses versus specialty physicians that are unique to the specialties and unique to the practice environment. And those are things that should be drawn up. Right now in the Collaborative Practice Act, if a patient does not want to see the APRN, he or she is entitled to ask to see the physician. And I think that's supposed to be posted in all of the practice settings. I'm not sure how that would be addressed if the patient does not want to see an APRN, for example, or And that was another reason why the 75-mile limit was there. So that could be an access. It could be an access issue. Now with the advent of telehealth, that may not be a problem, for that to occur. But I do think that it's important to look at the whole statute and come up with some guidelines that are favorable for both the Board of Nursing and the Board of Healing Arts, and have some sort of list for the consumers, and also for physicians and nurses to know who is a collaborative physician for APRNs. Right now, we have no idea how many physicians are in a collaborative practice agreement. At least we do from the board level, but it's not obvious to outside the board. And same thing from an APRN. I think it's important to know how many APRNs a physician is monitoring. One of the things that is in the statute is that a physician or an APRN cannot be mandated to collaborate with each other in a contractual relationship. However, the vendor for the correctional health, that was expected when they hired a physician, that they would sign a collaborative practice agreement, which is almost in contradistinction to what the statute says. So those are things that I think need to be addressed. I'm through with my comments. Thank you.
Thank you. Ms. Scheit, you may call your next board member.
Do we have a Board of Nursing member? Maybe someone that perhaps wants to address the things that are already in rule that address the comments that were just made? Dr. Miller, I think? Yep. I don't have any.
Can you hear me?
Yep.
Hi. I have a lot of respect for Dr. Taramina's comments, and I agree to much of what he had to say. While I guess I feel the need to remind everyone on this call that we have a limited, we're limited in what we can accomplish here in terms of joint rulemaking. So while the comments were made about specialty care versus primary care and other things that may be number of APRNs that a physician can collaborate with and the like, those are outside, I'll say, our jurisdiction for tonight as we speak of just the 25-mile rule. Another thing, and I don't want to, I guess I'm going to pose some hypothetical questions because I'm not sure this format really lends itself to us having questions and discussion back and forth, but what makes Missouri unique to every other state? I mean, we are the only state who has a 75-mile rule. So I guess I would, pose that question as we debate what's the evidence of thousands of patients that have benefited? Well, what's the evidence that thousands of people have been limited in their ability to seek care because of the 75-mile rule? The other thing in terms of quality, we have quality measures written into the statute. There are rules that talk about the chart review, that talks about collaboration every 2 weeks, that talks about the 30-day collaboration at the beginning of a relationship with between an APRN and a collaborating physician. So there are quality measures in place, whether that be with a primary care physician or a specialty physician. So I would pose to you that the quality is addressed. We have a very limited scope in what we can address here tonight. There is no other state in the union that has a 75-mile restriction for APRNs. And I agree with Dr. Taramina and others who have said that this rule is antiquated. We have proven certainly over the past 2 years with COVID that meaningful collaboration can happen through WebEx, through Facebook, through Teams, whatever platforms you're using. I think this is more, we're trying to put a mileage onto an accessibility issue. If I have a need in my clinic, I can get a hold of my collaborating physician, and I hope to be able to get a hold of that person within a reasonable period of time. It doesn't matter where she is physically in the world for me to be able to collaborate with her. If I have an emergency, I'm not going to call my collaborating physician. I'm going to call 911 or deal with that emergency myself. It doesn't matter where she's at in the world for that collaboration to happen. This rule is antiquated. It does not ensure quality. It's only control. And I challenge all of us on this call to be brave enough to own up to that.
Thank you. Mr. Leggett?
I was going to.
You were.
I was told that they couldn't see us back here.
No, I appreciate that. I believe she was concluded her comments, and you may call your next board member.
Okay, Dr. Tannehill?
Hi, my name is Dr. David Tannehill. I'm an ICU physician. I primarily practice in Washington, Missouri, which is a rural area, underserved area. And I agree with a lot of what Dr. Taramina had to say. They're excellent comments, and thank you. And the discussion so far has been great. And like Dr. Taramina mentioned, I appreciated the opportunity to read the comments that were offered. Just for full background, I feel very strongly that having an effective group of advanced practice clinicians in delivering team-based care is really, really important. And I think the criticism of our regulatory rules as kind of lagging behind that concept of team-based care delivery is a valid criticism. We expect team-based care delivery, but we don't regulate in a team-based way. And I think that's a real opportunity for improvement, no question. However, the question that's at hand, and the previous speaker appropriately pointed out that we are to be focused solely on the 75-mile geographic proximity rule. And one of the things that bothers me about this conversation is the geographic proximity rule has evolved over time. First, it was 35 miles, then it was 50 miles. And when we went from 50 miles to 75 miles, and if I remember correctly, that was actually done under the auspices of an emergency rule process. I may be wrong about that. But one of the arguments that I remember hearing during those discussions was that if we expand to 75 miles, then that should be enough of a radius to allow for all Missourians to be covered. By expanding it to 75 miles, the access to care issue becomes less of a concern because you're going to be because when you look at where all the physicians are, where the APRNs are, you should be able to accommodate everything. And so it bothers me a little bit that that's one of the arguments that was being used, and now we're being told that the 75 miles is limiting access to care. So that's one point I wanted to put out there just for us to consider. As far as the other criticism being that we're the only state with a 75-mile geographic proximity rule, I don't know this, but we may be the only state that actually outlines in statute that there will be a geographic proximity outlined in rule. So the rule comes from what the statute asks us to promulgate. And so I'm a little bit uncomfortable with the idea of just having nothing for a mileage restriction. The other thing that I am concerned about is even at 75 miles, if a patient does want to see the collaborating physician for an APRN, if you stretch that beyond 75 miles, that may become fairly onerous for patients. Practicing in a rural area, I have patients that end up in my ICU, and their loved one is dying on life support, but they're 100 miles away, and they don't have money for gas to come see their dying mother in the ICU. That's actually a pretty common scenario. I had that conversation with a family today, and so if you expand that to, if you have no mileage restriction, that may become burdensome for patients whenever they want to or need to see the collaborating physician for the APRN. And then the last point I'd like to make is that the geographic proximity rule was being described as antiquated. Again, maybe that's a reasonable criticism, but at the same time, antiquated doesn't mean bad. Antiquated doesn't mean it's the wrong thing. To Dr. Taramina's point, perhaps there are other adjustments that need to be made to bring us closer to regulating as a team while we practice as a team. But just because the concept is antiquated doesn't mean that we immediately need to throw it out. That's the end of my comments. Thank you.
Thank you. Ms. Scheid, you may call your next board member.
Do we have a Board of Nursing member that wishes to speak? Dr. Okay, Ann, you've not, Dr. Hine, did you want to go first?
Sure. I just wanted to respond just a little bit and clarify that, you know, I'm pretty sure that the physician is the one that has to be present on site every 2 weeks, so it wouldn't be putting the patient at any disadvantage. The physician is the one who would travel to that site. So I don't think that gas money is a reasonable barrier in this particular scenario that we're talking about. And I guess my other question would be, you know, last week at your meeting, you approved a 200-mile, you know, radius by road between the collaborating physicians for corrections. Is there any thought as to including that for everyone, all nurse practitioners and collaborating physicians in the state? That is all.
Thank you. Would you like to call on your board member to respond?
Sure. Does anybody have a response to that before we open up to another board member?
That was a public vote, so you would have known that we had a variety of opinions on that issue. We also asked for a number of quality metrics and reporting back within 6 months.
Okay. Dr. Razak?
Okay, thank you very much for being here from especially the Board of Nursing. I agree that there is a well-known place for nurse practitioners. They do a wonderful job, but I would disagree in way or form that they have similar experience as the physicians have. The critical thinking that the physicians develop over the years of medical school and residency, the nurse practitioners don't have that. They are not really at the same level of education. So once you take away the 75-mile radius, then they are actually free to do whatever they want to do. Basically, being 200 miles away, if I'm in St. Louis and someone is in Kirksville under me, there's no way I'm going to go see that patient from St. Louis. So I'm not sure why we are really having a problem with the 75 miles radius. We have got Kansas City, we have got Columbia, we have got Springfield, we have got St. Louis, places where there are a lot of physicians that can cover the 75 mile radius. What I am afraid of is that we don't want someone in St. Louis hiring 50 nurse practitioners and sending them all over town and not having collaboration or oversight from a physician. That definitely would not be a quality of care. If nursing is just doing, nurse practitioner is on their own and practicing, although I would say some of the nursing people from the Board of Nursing may disagree, and they say, well, they are at the equal level of the physician. I would totally disagree. I think that the training that the physicians get, the residency they go through, puts them at ease of doing some of the critical thinking that we see in our hospitals when we deal with the nurse practitioners that we have to oversee. So having said that, I'm not sure why 75-mile radius would be a problem, as we have so many cities that can cover. There are going to be physicians that can collaborate with all those nursings, APRNs. So having said that, I'll open it for comments.
I can't see everybody, so you're going to have to tell me if I have a nursing person raised. I think, is it only Julie?
Yeah, you have, Ms. Miller has her hand up.
Okay.
May I call your next board?
Okay. Dr. Miller, did you want to respond?
Yes, I do. No one, first of all, no one is offering that APRNs have the same experience or education. That's not a part of this discussion. It's not been a part of this discussion. It should not be a part of this discussion. Number two, in terms of having physicians collaborate with, I think Dr. Razik said 50 APRNs. It's written in the law. There's 6. 6 is the max, APRNs and PAs in combination, so that is not a concern. Also, by discussion last week that a physician cannot be required, they can't be forced into collaborating with APRNs. That's written in the law as well. So the 75-mile rule is an access to care issue. It's not a quality of care issue. No one is trying to say that our APRNs are trained and educated in the same way as physicians. No one is trying to say that APRNs are physicians. We are trying to say that APRNs provide care to patients who would not otherwise receive care. It's in the literature.
Thank you. Does that conclude your comments? Okay, great. Mr. Leggett, you may call your next board member.
Okay, Dr. James?
Good evening, everybody, and thank you. A few comments that I had as we talk about this geographic proximity. It has a twofold purpose. Most of the conversation this evening has been about the relationship of the collaborative practice, physician, and APRN. Part of the purpose of the geographic proximity is from the patient's perspective. And while we say that, the APRN can get in touch with their provider no matter where the provider is located, the patient doesn't have that access. And so my one comment is that we have to be careful about being so laser focused on the relationship between the providers when this is also about the access for the actual patient. That's one comment. The second comment has to do with the urgency of this issue on the heels of an emergency order. I think that there are some lessons that we can learn, but I think those lessons necessitate discussion and not a simple, quick decision, simply because in the case of an emergency, there appears to not be any discontent with what happened during an emergency. An emergency was just that. It was for that purpose. It was, a lot of things happened on the heels of an emergency, one of which was removing the geographic proximity. But there were a number of other things as well. So if this is a discussion to be had, I think this is a discussion to be well thought out, as Dr. Taramina presented, and not simply, oh, let's just go for the 75, for the geographic proximity, simply because it worked in the event of an emergency. It appears that these discussions seem to have such urgency at the end of an emergency, as opposed to having these ongoing discussions when the playing field is a little more leveled. The other comment that I had is that, I was one of those people that, number one, felt like the ruling for corrections would be used against us, and here you are proving that to be true. That's number one. Number two, suffice it to say that was a public vote, but I will tell you that part of the discussion was the fact that simply I am not a believer in any shape, form, or fashion that simply removing the mileage for corrections is going to solve their access and their provider problem. I have said that time and time again. I think that there is work to be done in a collaboration between the Department of Health and Human Services and the Department of Corrections. I think that corrections often ask the Department of Health and Human Services to be laxed about what we can do without any give on their end. Many of those facilities are older facilities where they choose not to put funding into, because if you actually put the funding into the telehealth for corrections, you will actually have a better access issue than removing the mileage. So I'm not really the biggest fan of the mileage because, again, we take points in time and we try to use that information to make broad projections when we actually should probably be sitting down. And I get that today's discussion limits us to the geographic proximity, but I think the discussion and the collaboration between the two boards far exceeds the geographic proximity.
Okay. Do I have any nursing members?
Ms. Miller.
Okay.
Yes.
You may go ahead and call your next board member.
Dr. Miller?
Again, I'll remind the State Board of Registration for Healing Arts that everything aside from the geographical proximity is outside our jurisdiction. A couple of other comments I would make is that I guess leveraging telehealth, while you say that, and I think it's important, and I think there's been, you know, some very serious laws around telehealth, it's starting to feel like, so telehealth is more effective, or leveraging telehealth would be the preferred, as opposed to having an APRN feet on the ground, being able to listen to heart and lungs. I feel like there's value in having people who have providers, who have patients who have access to providers in face-to-face collaboration or face-to-face encounters in the office. Also, I would say that in terms of here we are asking on the heels of corrections, I believe the State Board of Nursing began asking for joint rulemaking on this issue probably as long as 6 months ago, but there are others in the room who could probably confirm the exact date of when we started asking for the State Board of Nursing and the State Board of Healing Arts to come together collaboratively. And it was only after the urgency from the governor's office on corrections that we were able to get a meeting, a joint meeting with you. The other thing that I would say in terms of physicians traveling, I would remind everyone on this call that it is in the law that the collaborating physician is to be present every 2 weeks for medical direction, medical services, consultation, and supervision of the healthcare staff, which would give patients access to that physician every 2 weeks as they engage in the collaborative practice that is defined by state statute. The other thing I would submit to you is that patients would then have a choice. They can see the APRN who is local in their rural community, let's say, hypothetically, or they can travel. They can travel to wherever the physician is, if that's 75 miles away, if that's 200 miles away, if that's 250 miles away. It would be choice if they wanted to wait for the 2 weeks or if they wanted to travel to the physician. But I would say access to care provided by an APRN is better than no care. And yes, while telehealth is an option, should we not have the option to have a face-to-face encounter with a provider? And
I'd like to jump in and say I'm a little disturbed at the format. I think we're hearing from just one person over and over again, and we cannot see anybody sitting at that conference table. I think that it's unfair, and I want to make those comments public, that this is not the forum of which I thought we were going to be participating in.
Well, I apologize you're not able to see us better at the table. We can identify ourselves for the record, and I'd be more than happy to identify everyone who's at the table, but this is the video
We can't see
conferencing.
people, we can't see expressions, and the format is supposed to be a talk, and then each person has a say. We've heard from essentially two of the nursing people and one over and over again. I just want to say that.
We are rotating. Thank you for your comments, and we are rotating between the boards. The executive directors are keeping track of those who are raising their hand and are rotating between calling on those. Depending on how many people we have that wish to speak with each board, we'll plan to who comments next. I am happy to go ahead and identify who's in the room. I'm Kristen Polsmeyer. I'm sitting kind of in the middle. I'm wearing a light blue jacket.
I can't see you at all. So it doesn't matter that we can't see.
I'll wait for the camera there.
It's not fair.
The setup we
see
have.
us, we don't see you.
Well, certainly the cameras are a choice for everybody involved. But this is what we have in our setup for today. Mr. Leggett is to my right. To my left is Lori Scheidt and Deborah Funk. So happy to identify, but with that, let's see, are we going with the healing arts, our next comment? Is that correct?
So.
Okay, yeah, is that correct?
Okay.
Please call on our next board member.
Our next person, Dr. Glazer, did you have anything else you wanted to say?
Not at the present time.
Dr. Dorena, you had raised your hand and lowered it. You're muted, sir.
Can you hear me now?
Yes, sir.
I'm a little curious, and I would just like some frank discussion about if we're talking about the issue of all of a sudden the correctional centers and the nursing situations with correctional centers have initiated concerns, major concerns in the governor's circle or the governor's office. I'm curious, in the APRN world and at your board, did you have any correctional center APRNs come for advocacy or come for your help? And I mean, I know what we sit at as far as the healing arts with correctional centers, and I know it's how difficult it is to get information, whether it's governmental or whether it's federal or whatever. But being that the fact that you're supervising their licenses and they're in trouble and and the companies that are hiring them are in trouble, did they ever come to the nursing board and ask for your advocacy or your assistance? Or is this just something that's just come out of the governor's office, and now that we're talking about collaborative practice for the 400th time, that this is something that you have taken an interest in? Just clarify that for me. Thank you.
And I want to remind everyone the scope of what we're focusing on for this meeting today is going to be the 75-mile-an-hour requirement. There's a lot of things that are being brought into the discussion, but with that, I am going to go ahead and turn it over to the Board of Nursing for their next comment.
Yeah, so, and I'm sorry, but I saw Adrian Fly and Donna go below, but I'm not sure who had their hand up first. It's a little hard for me to also see. So I'll start with Adrian, and then Donna will go after the healing arts member. So Adrian, did you want to go next? Adrian Anderson Fly.
Yes, thank you. That is my name. I'm the public member of the State Board of Nursing, and I have been for 13 years. And I can tell you that attempting to get the board registration of healing arts to sit down collaboratively to talk about the distance limit is something that goes way back. I posed to my colleagues, and it was posed to you, again, the question about what is so special or so problematic about Missouri that we need a limitation that other states function perfectly well without. They don't seem to find, at least as what we see in the literature, what we see in the journal. We all read the journal that's put out by the National Organization of the State Boards of Nursing. We don't see people saying, gee, in our state, we're getting really bad outcomes, bad quality of care. It sure would be good if we had a restriction on how close that physician needs to be to that nurse to make sure that that doesn't work. And the comment saying that in a rural area, you really, 75 miles will do it. Think about a state like Montana. There are states all over the country that have an incredible variety of settings, whether it's urban areas or rural areas, huge suburban megalopolises, and they all function okay without having this restriction of a geographic limit. And so I would ask the members of the Board of Healing Arts, what is the reason for having it? As opposed to saying why we shouldn't get rid of it. What is the positive that comes from that can only be achieved by maintaining it? Thank you.
Thank you. You may call your next board member.
Dr. Matthews, would you like to respond? You're muted, ma'am.
No, I don't know what's wrong with my mic. Can you hear me?
Okay, I'm turning you back up.
Thank you. What's at issue is state law. And we're not the legislature. So that's why we are in this situation. Did you hear me, Adrian?
I did. Laws can change.
Thank you for your comment. Did you have anything else to add?
No, I just apologize. I had told Jimmy I had until 8. I have a sick child. I don't like to bow out in the middle of a discussion, so I don't know how much longer we're going.
Certainly. Well, we're ready for Board of Nursing.
Okay, Dr. Donna Glow.
Some of this discussion is leaving me just a little bit confused. I realize that being the only state with a specified geographical mileage limit is unique. But are we also going down the road to where we're going to have mileage requirements for one set of APRNs and then different mileage requirements for another set of APRNs?
Okay. Board of Healing Arts response?
Does anybody in particular want to respond to that? Dr. Razak?
Yeah, I think we don't really have to have two different specifications for what you're saying. It should be one and only one. I wanted to respond to Dr. Miller in saying when I said we can have someone in St. Louis, maybe a group of 10 physicians that can hire 60 and have a collaborative agreement with 60 APRN, and they can be all over Missouri. That's what I was saying. It's basically asking for independent practice. When we say it's 200 miles or there is no radius at all, a physician sitting in St. Louis should probably not be collaborating with someone in Kirksville. And that was my point of saying, and I think it was really derailed by saying that you only allow 6 APRN. I understand you only have 6 APRN, but you can have 10 physicians in an institution that can sign up with 60 APRN and then can send them everywhere and can and practice independently. And that's what the issue is that we need to cut the chase here. And I think it's really trying to be as an independent practitioner, because there is no way for a physician sitting over 200 miles to be able to go and visit and the patients will lose access to the physician. Thank you.
Thank you. You may call your next board member.
Dr. Hine, you did have your hand raised. Did you want to speak?
Yes, I did. I guess I would just like to say that we approached the Board of Healing Arts in good faith to discuss this issue. Disagreement on how to deal with the subject matter is very fair and very appreciative. I would like to add very clearly for the record that no time has it ever alleged that APRNs were equivalent in training or education to physicians. Yet, members of the Board of Healing Arts felt it was necessary to remind everyone on this call that nurses are inferior to physicians. Again, while we can disagree over how to deal with the mileage limitation issue, until there is mutual respect between nurses and physicians of any kind of collaboration is extremely difficult. That lack of respect was very clearly demonstrated again this evening. So I'm not sure if this call even needs to continue.
Thank you for your comment. We'll go to the Healing Arts.
Dr. Carter.
Thank you, Jimmy. I just want to say, I mean, I've spent most of the evening just listening, and I appreciate both boards coming together. And I think we've heard a lot of very intelligent comments across the spectrum. But I feel that, you know, this is somewhat of a missed opportunity to have a more holistic, broader view of how we're going to go forward with collaborative practice. I mean, for those of us who all feel that it's valuable, that it does provide a service for access, I think it's a shame that we're only having a discussion with such a narrow scope tonight about one rule, when there are so many opportunities to talk about ways that we can ensure quality. And with the vote last week, of course, I believe I made the point that despite the results of the voting, it was more important for me to be able to demonstrate outcome measures or have some evidence, because I think that any rule, any statute should be evidence-based. It should not be arbitrary. There should be a reason behind it. So I think that there's an arbitrary nature to the rule, but I think we need to ensure that there are some safety guidelines in place. So I would recommend what Dr. James proposed, is to have a broader discussion, possibly appointing a committee to look at collaborative practice and just come up with a new, fresh way of looking at it. That's all I have to say. Thank you.
Thank you. Board of Nursing.
Did you tell who had their hand first?
Ann and Julie.
Okay, Dr. Hyan?
I just wanted to clarify that the only scope of practice, or the only scope that these two boards have to deal with, is the 75 miles. That is the only joint rule that we have the ability to impact right now. Everything else is in statute, which goes through our legislature, not the two joint boards. That is why the scope is narrow, because it is a narrow scope of what we have the ability to impact.
Thank you. Board of Healing Arts.
Dr. James.
Good evening. I wanted to go back and just respond briefly to Nurse Glow. Am I saying that right? She just asked the question in terms of, are we really headed in the direction of having two sets of rules for APNs? And I think the short answer to your question is actually yes. And I think part of the discussion about that is because corrections came to us, number one, as a system, again, under this sort of emergency reprieve kind of conversation, which I have to admit that I'm challenged with. Like, it's kind of like we don't have enough right here, right now. And corrections being a system in and of itself, ask us to deal simply with the correction system because of the way that it's regulated and it being a relatively closed system. When we talk about APRNs as a whole, I will again say, whether it's statutory, whether it's the two boards together jointly promulgating, we have to find a better way to discuss the totality of the collaborative practice agreement and not simply the geographic proximity. And I get that tonight we were asked to just address the geographic proximity. But the short answer to your question is that corrections came as a single entity, almost with like a single administrator, if you will. Whereas when we talk about APNs as a whole, some of them are independent practitioners, some of them work for various systems. And so the blanket rule really is quite concerning to just say, oh, since corrections has 200 miles now, we now have, we should now make it 200 miles for everybody. So I just kind of wanted to provide that response and at least some understanding as to why the rule was sort of given to corrections, but we're wanting to have a broader discussion about the APRN collaborative practice as a whole and not just the geographic proximity. I understand and I respect, you guys are saying her last name and I don't know it, but she's showing up as Ann. So I don't want to be disrespectful to her or her title, but I respect her comments saying that tonight's agenda is strictly about the geographic proximity. And I will just submit again, maybe in a different way of framing, that however we came together tonight to be restricted to geographic proximity, I think we need to sort of table the conversation in a manner that we can create a larger discussion about collaborative practice, however we need to do that. That is my input and my response to Nurse Glow.
Okay, thank you. Board of Nurses, next.
Trevor Wolf.
Hi, everyone. Thank you. So I want to respond to a few things. Again, I'm trying to just sit here and listen like Dr. Carter and kind of absorb everybody's views. And I appreciate Dr. James, Dr. Matthews, everybody's views on wanting to have a discussion to talk about discussions about the Collaborative Practice Act. And I think anybody here would appreciate the opportunity to get together, come up with something, and go to the legislature with ideas at some point. However, tonight we are here about the 70 miles. And when we did come to you, I know the corrections came to you at some point, but we've also been trying to get this meeting for ever since at least the 6 months that I've been on the board without success until tonight. So in Missouri, we have 6 million people, 2.23 million, or roughly 37%, are in rural areas with lack of access to the amount of physicians that are found to typically congregate in urban areas around medical schools and such. I have landed in many of those rural areas as a flight nurse. They are nowhere near an area that has enough physicians to keep up with that population, have been bolstered by APRNs able to provide care to the old one-doc towns of the past. They're now one-doc towns or two-doc towns with multiple APRNs able to provide care to these folks. Immediate access to the collaborative physician, as we've talked about before, can easily be taken care of, because when somebody makes an appointment, or that collaboration between the physician and the APRN should communicate, that whole collaboration, the physician and the APRN communicate with those patients to allow them to have that choice that they do have legally to be able to ask for the physician. And as Dr. Miller has pointed out, that choice is there because that physician is required to report to that area for coverage once every 2 weeks. So those patients who ask for the physician will have that ability to see that physician. And again, as everybody on both sides has spoken about, with the advancements in telemedicine have been wonderful, and they've allowed us to reach out to those rural areas especially from the emergency side with strokes and care, to have an immediate, have a neurologist on to be able to see that. And that's wonderful. But again, as Dr. Miller pointed out, what is better? Just a video call or somebody who you collaborate with on the ground to lay hands on that patient. There is a relationship, or should be a relationship. There's a responsibility of both the physician and the APRN to understand each other's practice. As somebody who's worked in the emergency department in my career, I understand that collaboration very well. And I know my physicians that I work with extremely well. We know each other's capabilities, and we know how to have that team approach. And yes, that conversation can happen at another time about collaborative practice, but tonight I would like to just, we really need to get back on track about that arbitrary 70 miles. It started off as 25, went to 50, went to 70, and now the data is there of 21 months of those suspended, those waivers that were there. That data already exists, and that was only positive data. There is no negative data showing that that mileage restriction caused any decrease in quality of care. Again, I respect everyone's concerns, and we want to do the best for the public. That is our job. But I really, truly believe the best thing we can do for the public is get rid of this arbitrary number so that we can reach out to the most patients we can. And my comments are complete. Thank you.
Thank you. Healing Arts, your next board member.
Dr. Matthews?
Can you hear me? Okay.
Yes.
I just wanted to do a both and because Ann and I do want to affirm that I take seriously the specifics of the statute. And so I hear what you're saying, Ann. I brought this up as well. And I appreciate the suggestions about a thoughtful team that thinks about this, not because we have the authority to change statute, but because we have the collective expertise to make recommendations. So Dr. Taormina made that initial recommendation, and I know other board members have spoken to that as well. I also do want to offer apologies because I do need to step off, and from a mechanics, I'm just going to count on our board to follow up with me. So I thank you all for your time. I thank you for your passion, and hope you have a good evening.
Thank you.
Thanks, Doc.
Board Nurse, go ahead.
Dr. Miller.
Because we are here, not because it's on the agenda, but because we are here to engage in joint rulemaking, and there is one rule that we can do that with, and it's the 75-mile rule. And because the 75-mile rule is antiquated, I would like to make a motion that we amend the rule by deleting all of B in 20 CSR 2200-4.200 and 20 CSR 2150-5.100. I would like to make that motion.
I second the motion.
I will second that. Okay.
Thank you for oh, go ahead. The comment, I wanted to thank for the comment. Any actual motions will be after the discussion's completed, and we'll turn it back over to both boards to complete any necessary business they may have at that time. So we'll keep discussion moving, but certainly each board may take up any motions they have at that time.
I think the
did you have
discussion is
anything
not
to finish your comment?
I think the discussion has been beat to death.
Well, we do have some other hands raised, so if that concludes your comment, I am going to turn it back to Healing Arts for their comment.
Dr. Razak?
Yes, I want to take an opportunity to apologize if anyone really felt that as a Board of Healing Art member that we were saying that nursing is inferior to your doctors. That is absolutely taken out of context. What I was trying to say is their education is different, not that they are inferior. So I really felt offended by the comment that came across that we are saying that the nursing is inferior to the doctors. That was totally out of context. And And if someone felt, all I was saying is the education is different, and it is different. So having said that, if my comments went to that level where some of the nursing staff is thinking that they are inferior to the doctors, that is totally out of context. So I would rest my case on this issue here, except I can say I have a utmost respect for nursing. If I'm sick, who do I want to be next to me is the nursing. The doctors will be far away. It's the nursing that takes care of the patient in the hospitals. So anyway, I just want to make sure that by the end of the day, people don't leave here by saying that the Board of Healing Arts comment came in and they said the nursing is inferior than the doctors. That is not the point. Thank you.
Thank you. Board of Nursing have the next comment?
I don't see any other hands up.
I don't see hands.
Well, as the Board of Nursing has no additional comments, we can draw this conversation to a close. I'd like to thank both boards for participating in the discussion today. Now the discussion is wrapped up, I will turn over the meeting to the Missouri State Board of Nursing for any necessary business related to the discussion. When they finish, the Board of Healing Arts will be given the same opportunity. If either board wishes to make a motion based on the discussion today, they may do so during their respective portion of the meeting, and I will now close the discussion portion of the meeting. Thank you to everyone.
Thank you very much. This is Dr. Kim, President of the Missouri State Board of Nursing. Thank you very much for facilitating this discussion, and we appreciate the thoughtful discussion that came in today. And so for the Missouri State Board of Nursing, we will finish necessary business, and then we will entertain a motion from our board members. So to conclude our necessary business, the statute requires the maintenance of geographic proximity. Actual mileage is included in the regulation. The first bullet, A, in the regulation states the physician and nurse not to be so geographically distanced to create an impediment to effective collaboration in the delivery of healthcare services or the adequate review of those services. I would advocate to eliminate all of B. We do have to keep C and D, as those provisions, as we've articulated earlier, are in the statute and may only be changed through legislation. Again, I would mention that the waivers were in place for almost 2 years, and the State Board of Nursing saw 0 complaints related to the geographic proximity. I would also reiterate that this restriction of APRNs not having to be within the 75 miles of collaborating physician affects APRNs providing services through the VA. So if our veterans are good enough to have quality of care that don't have the restrictions of a 75-mile radius, I would advocate that all of our patients, regardless of the population, should have equal care as our vets do. I would also believe that this standard should apply equally to all Missourians. And again, I would reiterate to the board that both boards have mechanisms for addressing patient and provider complaints. That's why we exist. On behalf of the Board of Nursing, again, we take these very seriously, and you can be assured that we will continue to do. I'm confident that the Board of Healing Arts does as well. So we have those mechanisms already in place. So asking for additional studies or worrying about if discipline is needed, we already have that. That's what we do. That's what we were appointed to do. And again, there's been no evidence in Missouri that's brought forward to the State Board of Nursing that the lack of mileage restriction has led to poor patient outcomes. The Missouri Hospital Association, Missouri Nurses Association, Barnes Jewish Medical Group, Oak Street Healthcare Centers, and numerous physicians and nurses in the state have asked us to meet jointly to eliminate this mileage restriction. It is time that we are not the outlying state, the only state that has this restriction. So at this point, is there any further discussion from Board of Nursing members before I entertain a motion? Hearing none and seeing none, I will entertain a motion from the Board of Nursing.
Bonnie, it's Julie. I would like to make a motion that we amend the rule by deleting all of B in the said general rules.
Okay, that's the first. Is there a second?
I second that motion.
Okay, call for the vote.
Julie, yes.
And yes.
Janae, yes.
Adrian and Donna, I didn't hear you. I'm sorry.
Adrian, yes.
Yes.
Was waiting
Yes.
for Donna.
Oh,
Donna,
sorry,
yes.
Dr. Glow, yes.
Okay, and Bonnie, yes. Motion carries for the State Board of Nursing.
Okay. Dr. Glazer, would you like to speak?
Sure. First, I want to thank everybody for joining us, and I want to make sure that everybody on the call realizes that we all appreciate the work that each board member does on both boards, and we appreciate the professions of which we represent. And I don't believe that any member of the Board of Healing Arts had any intention of placing one profession above the other. I believe that we all have our roles, and we're all very important in the care of our patients. And in no way do we diminish the roles of nursing, nurse practitioners, physician assistants, et cetera. Everybody is very, very important and equally important in the care of the patients. The concerns that we have, and I think were raised by several of the board members, is that there are many ways I think we can improve the collaborative practice relationship and the care of our patients. I think we're all very concerned about arbitrarily eliminating the geographic radius that's been put in place. I think that there's other mechanisms that we need to explore to improve access and improve care throughout our state. And our main concern as the Board of Healing Arts is the care of our patients and all of the citizens of the state of Missouri. I appreciate all the things that everybody has said, and we all are interested in making things better. So with that being said, I would be happy to entertain a motion from the board, a member of the Board of Healing Arts at this time.
Dr. Glazer, am I allowed to have a point of discussion before
I think
the
so that
motion?
we can have discussion before we vote.
I just want to make a point of clarification to the VA system that was mentioned. And I would just like to publicly say that the VA has a much more integrated system of care via their electronic record and other systems that they have in place to make the elimination of the geographic proximity a much more plausible feat. And again, you're talking about a coordinated system of care, and you're talking about a single system that is far better than all of the silo systems outside of the VA system. And so the comparison of if it's good for the VA, it should be good for everybody. I sort of disagree with the comparison because we're not comparing apples to oranges in that instance.
Any other comments before we take a motion, or is there anybody have a motion?
I'll make a motion that we not eliminate the geographic proximity that is currently designated at this time.
Do we have a second for the motion?
Can I make a second, but see if Dr. James would be willing to accept a kind of an editorial revision to her motion and word it more in the positive, which is to maintain the collaborative practice rules as is.
I'll accept that. I'll accept that.
So we have a motion and a second. Is there any further discussion? Seeing none, Jimmy, would you call the vote, please?
Dr. Glazer,
Aye.
Dr. Taormina,
No.
Dr. Carter, did we lose Dr. Carter?
I still see him, Doctor. Can you hear us?
My vote's aye.
Okay, thank you, sir. Dr. Drenna,
Aye.
Dr. James Halbert,
Aye.
Dr. Matthews, oops, she left, I'm sorry. Dr. Razak,
Aye.
Dr. Tannehill,
Aye.
motion passes.
We're done. Nothing changes.
You have a motion for adjournment by both boards.
Bonnie, do you want to entertain a motion to adjourn the Board of Nursing meeting from someone, please?
Yep, I move to adjourn the meeting. Motion to adjourn.
Call for the second.
Adrian with the second.
Okay.
Call for the vote for Board of Nursing, please.
Julie, yes.
And yes.
Jeanette, yes.
Connie, yes.
Trevor, yes.
Adrian, yes.
I think Donna said yes. Bonnie, yes.
Thank you.
Board of Healing Arts, do we have a motion to adjourn?
Motion to adjourn?
Do we have a second?
Second.
Jimmy?
Dr. Glazer,
Aye.
Dr. Taormina,
Aye.
Dr. Carter,
Aye.
Dr. Drenna, Dr. Drenna. You were muted, sir.
Aye.
Thank you. Dr. James Halbert,
Aye.
Dr. Razak, Dr. Tannehill.
Aye.
Okay. Anything else?
I don't have anything else.
No, that's it.
Thanks, everybody.